Good afternoon, everyone, and welcome to another webinar in our series, Bringing Data to Life. My name is Eleanor, and I'll be your host today for our webinar, Connecting the Dots, the Benefit of Linking Data on Health and Wealth. We're delighted to see so many of you join us today. Before we start, we'd like to remind you that this session is being recorded and will be available on YouTube after the event. The slides and recordings for all of the series is available via the ONS website, and everyone signed up today will receive a link once today's recording is available. If you are using the Microsoft Teams app and you would like to turn on live captions for this webinar, please click on the More button across the top of your screen. For those who haven't used this before, it's the button with 3 dots to the left of your camera button. Once you click More, scroll down to Languages and Speech, and then select the option which will show live captions. With so many of you joining us today, the chat function is closed and all questions will be facilitated through Slido, and I'll cover that in just a moment. The webinar series is for everyone, so please share this recording and slides when they're available and join the conversations on socials using the hashtag statistics for the public good. Lastly, you will be invited to complete a short survey at the end of the webinar, and we'd really welcome your feedback on the webinar series and the statistics we produce at ONS. The session today is interactive, so there will be some questions for you, and you can ask questions to our speakers throughout the event. We'll have time to answer as many questions as possible in our Q&A section after the presentations. Please join in by scanning the QR code on your screen or heading over to slido.com and using the code BDTLData. If you're using the desktop Microsoft Teams app, you can click the S Slido button at the top of your screen and Slido will appear. Don't worry if you miss the Slido code, this will appear on the footer of every slide. I'm delighted to introduce our speakers today. We'll first hear from Johnny Tinsley and Emma Sharland from the ONS. Johnny will explain what data linkage means for the ONS, show you how we do it and how we keep personal data safe. Emma will explore user cases and share insights from our recent publications where we have linked health data to earnings data. We're also pleased to be joined by Emma Cox from Endometriosis UK. Emma will explain what endometriosis is, the impact of data, and how they've been working with the ONS. Thank you once again for joining, and I'll now hand over to Johnny to get us started.
Thank you, Eleanor. Good afternoon, everyone. My name's Johnny Tinsley. I'm head of data in the health analysis team here at ONS, joined by my colleague Emma, who'll be talking next. Very briefly, before she gets onto the exciting bit about the data analysis we've been able to do with some of our linked health and wealth data, I'm just going to briefly explain a little bit about data linkage to help set that up. Some of you, or probably all of you, know that ONS runs the census every 10 years, for example, and we also run a number of surveys. And for any survey or census or other data set that ONS might acquire from other government departments, it's only going to have a certain amount of information in it. So even something like the census, as incredible as it is and all the information that it includes in it, we can only produce a certain number of statistics from that data source on its own, because there's only ever a finite amount of information in it. One way we can then therefore enrich that data is if we can link it at an individual level to another data set that includes information that the original one does not. We are then able to produce more or different statistics. That opens up a whole range of opportunities without needing to actually expand the original census or the original survey itself. So it can be really useful. I'll just tell you a little bit about conceptually how we might do that. So next slide, please. Often the best possible way to link two data sets together would be if they have a common unique identifier. So again, a lot of you will probably be familiar with NHS numbers. You'll each have one. So the NHS might have more than one data set that you would be on. And the easiest possible way to therefore link the two data sets together and the 2 bits of information about you would be through the NHS number. But sometimes when we want to do data linkage, there won't be a common unique ID like that. And so often when we're trying to link data to enable those better statistics, we'll have to use personal identifiers that appear on the data set to achieve that. So names, addresses, dates of birth. And obviously this is a pretend example with no actual personal data on it, but it's just to illustrate that. And I'll talk a little bit more about security later, but just briefly, one aspect of security when we do this is we'll separate out these identifiers from the actual attribute information. So if we're talking about something like health, then the health conditions, or as you can see, occupation and ethnicity. And two separate teams will effectively deal with these two bits of the data set. So one team who are highly trained and security cleared will work with the personal identifiers and use matching techniques, deterministic and probabilistic matching techniques to make sure we're identifying where the same person appears in both based on things like name, address, dates of birth. And then based on the results of that work can provide what we would call a linkage key. As you see in the middle there, where we can then link kind of the unique identifiers or the codes of the two data sets together. And then only that linkage key can then be brought forward to pass on to the analysts, where the analysts only have access to the attribute information, so de-identified data, and can then use that linkage key to link the two sets of information for the same person. And as I said earlier, that then obviously enriches the data. So on the left, the data set only includes things like sex, ethnicity, and occupation, but then through the linkage, we can then add in things like their conditions, which only appear in database 2, and therefore create a much larger useful data set through that process. Next slide, please. And first click, please. And so just to make that a little bit more real, I'm going to talk about the data that Emma's analysis team have actually used for some of the work she's going to tell you about. I've mentioned the census a lot, so we obviously have the census data from 2011 and 2021. What that gives us is kind of a central spine of data for most of the people that were here in the country in those two time points. There are some limitations to that. So in any census, we don't always capture everyone. And then obviously, as we move away from the census, people will arrive or leave the country that start to make that data a little bit out of date. But there are still a wonderful central core of data that tells us an awful lot about everyone in the country. And then using the techniques I just described, we can then link to some of the other data sets that ONS has legal access to for statistical purposes. So during the pandemic, that looked like health data in one example that our area were using and linking to the census. And you can see a whole range of different health data sources that we get from the NHS there. During the pandemic, it meant that we could look at COVID-19 mortality broken down by kind of socio-demographic characteristics that the census captures, like ethnicity, for example, and then also control for comorbidities that people clearly had from the health data. And we're able to produce, therefore, new exciting statistics on that no one else was able to produce, doing things like breaking COVID-19 mortality down by ethnicity, which was really useful for decision makers like Sage during the pandemic. And then more recently, which is what we're going to talk about today, we've then linked on labour market data about people's pay in particular, and also benefits. And what that allows us to do, as Emma's going to tell you about with some specific examples, is to look at where people are diagnosed with certain conditions or get treated for certain conditions, which is what the health data tells us, and then see the impact on their labour market outcomes, both kind of before and after that event, either that diagnosis or that treatment. Next slide, please. So just briefly before I hand over to Emma, some of you will know that for the census data, we keep that secure and only release it after 100 years. We take data security really seriously here at the ONS. And so just a word on all of that. There's something called the 5 Safes framework, which some of you may have heard of, that applies more widely than ONS. Other providers of secure data research environments, for example, will kind of follow this framework. In the ONS context, just to go briefly through each of those, that will look like things like I talked about earlier with the data linkage, where we'll de-identify the data as quickly as possible and have as few securely security cleared trained researchers accessing the identifiable data as possible. In terms of secure settings, ONS has a really secure central data platform with need-to-know access controls and protected monitoring that tracks what data has been accessed by when and by whom. Our people, as I mentioned, are trained and security cleared. The projects we do and the new statistics we produce using this linked data all have certain governance about which projects can go forwards, and that includes scrutiny by an external ethics committee to make sure there's independence about whether actually this work is for the public interest, and that the balance between that public interest and any data protection risks is in the public interest for the project to go ahead. And then when the analysts then work with that de-identified data, ultimately they will produce results, so data tables, models, and whenever those modeling or data table results come out of the secure environment ready for publishing on our website, then they will be scrutinized and cleared to make sure there's no way that someone external could drill into that data and figure out something identifiable or personal about anyone whose information is then contributed to the aggregate data or model output. So that's the end of my section, I think. I'm going to hand you over to Emma for the more exciting stuff about the results of some of the projects we've been able to do with this data. Thank you.
Thanks, Johnny. Hello, everyone. So I'm Emma Sharland. I'm head of the Health Research Group in the Office for National Statistics. So as Johnny said, I'll be presenting on some of the pieces of work we've been doing in this space already using the linked assets that Johnny's mentioned. So just to give a bit of background on the work, we have a kind of large programme of work looking at the health and work data, and this has been born out of things like the Get Britain Working White Paper and the Kickstart Economic Growth missions that have been produced by the government, which is identifying that economic inactivity due to ill health is a national priority. There's been a lot of commitment from the government around expanding services like talking therapies to reduce mental ill health and improve employment outcomes, and lots of policy interest in the work that we've been doing from the Treasury, Department of Health and Social Care and NHS England as well. If you could go to the next slide, please. So just to give a bit of an overview of the projects we've done so far, and one of the projects we've got upcoming on this work. We've covered quite a range of topics so far, looking at interventions for different health conditions like bariatric surgery and talking therapies, but also looking at conditions like endometriosis as well, and also some life events and health events like motherhood and adverse pregnancy events like pregnancy loss, miscarriages and ectopic pregnancies and stuff. We have a publication out in a couple of weeks on the NHS Diabetes Prevention Programme, so that's out early November, which is our latest one in this programme of work. If we could move to the next slide. So the next slide, there's an interactive question for you all. If you could go on to Slido, please. You've seen there the topics that we have started looking at and published so far. If you could go on to Slido, we're asking the question, what other health topics are you interested in? So what topics do you think we should look into next if we had the data on it? Okay, mental health, yep. So mental health, we've started to touch upon with the talking therapies release we've already done. We have some other projects looking at talking therapies in the pipeline as well, but we are looking to get more data on mental health to do a bit more in the space. Diabetes, yep, that's coming soon. Keep an eye out for that one. Yep, menopause, also something we've been discussing, so that's good to see that there. Neurodiversity as well. Yeah, something we haven't got. Oh, can we go back? Are we able to go back? Thank you. And neurodiversity as well is something that we've certainly had discussions about, but we're a little bit limited on the data we have on that at the moment, but hopefully in due course we might be able to look into that as a topic a bit more. Lots and lots there. That's great. I'll be using this after this webinar to have a look into different areas we can research and if they align with kind of our current priorities. Thank you. Fab. So just to give a bit of an overview before we go into the results at kind of the impact we've had with some of this work already. So as you can see on the slide there, there's been lots of engagement from the media and different charities on the work that we have. Many charities have sort of put comments out on the work once it's been published, and also provided some really interesting stories from members of the public around lived experience when we've published some of this work, particularly in our endometriosis release and our adverse pregnancy events and also motherhood releases. We had a lot of engagement from charities in those releases to share some of those stories, which has been great to be able to apply the actual lived experience with the work that we've been doing. But also the work that we've done so far has been critical in a decision from the NHS England's Health and Growth Accelerators programme. So approximately £45 million was allocated in the autumn budget to fund this programme, which is currently being piloted in 3 integrated care systems that have high levels of economic inactivity. And also NHS England and Treasury are currently using the work to make decisions on further investment in the NHS, which is great. If we could move across, I think we have another interactive poll now. So again, if you could go on to Slido and look into answering this poll. So we have a question on how does undergoing bariatric surgery affect employees' earnings, and do they increase or decrease afterwards? Okay, so lots of people thinking increasing at the moment, a little bit of movement on the decrease, but broadly everybody's in agreement. So just about to move on to some of our use cases, and bariatric surgery is the first one we're going to come to. So we can move to the next slide, I think. There, thank you. Okay, so just to provide a bit of an overview on a few of the projects, I'm going to cover the bariatric surgery one first. So the aim of this work was to understand the average change in earnings and probability of being a paid employee that was attributable to having bariatric surgery. So we've looked at the people who have had a record of having bariatric surgery within hospital records between April 2014 and December 2022. And we've been able to, using a fixed effects regression modelling approach, estimate the change in their earnings and also the probability of them being in paid employment following the surgery. So as you can see on this chart on your screen now, this is earnings. So there's an initial drop in earnings. So time 0 on the left-hand side of the chart there is the time of the event, so time of the surgery. So initially, once someone has a surgery, you see a drop in earnings, which makes sense for recovery time following quite major surgery. But after 6 months, we're starting to see an increase in earnings that are peaking at around £84 by 5 years after. By nearly 5 years after the surgery. So what we're seeing there, and in answer to the Slido question that you just answered, we do see an increase in pay from 6 months in surgery. Can we move to the next slide? Fab. To look at the next results on this, so on the left-hand side, again, we have one looking at earnings, but this is earnings amongst people who are in paid employment. And what we see here is we see that reduction again following surgery, but we don't see a huge increase from the 6 months surgery point onwards. But what we can see in the right-hand side, in the chart on the right hand side, is the probability of being in paid employment. So again, we see a slight reduction after the surgery, but then there's quite a big increase by 4 percentage points on average by 5 years after the surgery. So this shows that the increase in earnings on that first slide is likely to be driven by people that are entering the workforce following surgery who weren't previously working prior to that, rather than an increase in earnings of people who were already employed. If we could move to the next slide. Okay, so another one of our releases, so there's a QR code at the top there if you would like to read more about them. We looked into and we published in June this year a publication looking at hospitalisations for serious conditions. So this used a very similar approach, but looked at several different conditions within hospital data, so cardiovascular disease, respiratory disease, diabetes, chronic kidney disease, cancer, and musculoskeletal conditions. And what we were able to do in this analysis was look at, again, employee earnings and also the probability of being in paid employment, but also the probability of receiving social security benefits as well. So you can see on the right-hand side of the screen there that the average total loss in earnings over 5 years for all of those conditions was quite high, so ranging from nearly £19,000 over 5 years for stroke, all the way down to sort of about £1,500 for respiratory conditions at the bottom there. So quite significant losses in earnings if someone was hospitalised for one of those conditions. Next slide, please. And just to give a bit more of an example with the employment and the benefits results we found. So this is looking at chronic kidney disease, so one of the conditions that we looked at for this release. And you can see on the left-hand side chart the probability of being in paid employment following a diagnosis of chronic kidney disease is on the decline there. So you can see that kind of purple line decreasing over time. But what we can see on the right-hand chart is that over time, the probability of receiving benefits increases. And so this is showing that, you know, as people are being diagnosed with chronic kidney disease, they are leaving the workforce and probably moving on to receiving benefits. So there'll be probably an interest then from policy side of things in looking at how they might reduce potential diagnoses for kidney disease in the future to keep people in the workforce. Next slide, please. So moving on to the last example before I hand over to Emma from Endometriosis UK is our endometriosis release. So for this release, we looked at an impact of having a hospital diagnosis of endometriosis on labour market participation and progression. So in this analysis, we did a pre-post analysis using a fixed effect regression model again. And what we found, as you can see on the chart here, that following a diagnosis for endometriosis, we do see a reduction in average pay across all women who are in paid work or not paid work of around £130 lower than pre-diagnosis levels 4 to 5 years after diagnosis. We could move to the next slide. And then as per the bariatric surgery release, we had a look at those people who were in paid employment. So for those, it was a slightly reduced amount, but still a reduction in £55 lower than pre-diagnosis levels 4 to 5 years after a diagnosis. And then when we looked at the probability of being in paid employment, we also see a reduction there. So a 2.7% percentage point reduction in the probability of being in paid employment following a diagnosis of endometriosis 4 to 5 years after diagnosis. So I'm going to hand over now to Emma Cox, who was someone we worked quite closely with for the endometriosis release, and she can talk about a little bit more about how we work together and the work they're doing.
Thank you, Emma, and thank you, Johnny. So I'm Emma Cox. I'm Chief Executive at Endometriosis UK. And what I'm going to just do in the next few minutes is talk a little bit about what endometriosis is and what we do as a charity to give you some context. And then I'm going to talk about the importance of data and how we worked with the Office of National Statistics on this project. So next slide, please. So what is endometriosis? Well, it's 1 in 10 women and those assigned female at birth have endometriosis. So that's it's active from puberty to menopause, although impact might be felt for life. And in the UK, that's over 1.5 million and over 200 million worldwide. So I'm just flagging that because you will know someone with endometriosis, whether you know it or not. So moving on, please. So what is endometriosis? It's a disease where cells similar to those lining the womb grow outside of the womb itself. And so they form patches of endometriosis, and these cells react to the monthly hormonal cycle, and that can cause inflammation, pain, scarring. I'm sure you can imagine. And one of the main issues is the endometriosis itself can impact on organs, but also it causes adhesions or scarring that can join those organs together. And with this picture, we quite often see a picture of a womb just nicely floating in space. But if we go on to the next slide, I think one of the things that we need to remember is that there's quite a lot of stuff wedged in our pelvic cavity. And so if you can imagine, you've got your bowel, rectum, vagina, also there's various nerves, your bladder, etc. And so that endometriosis can impact on different organs through your pelvic cavity, and sometimes further throughout the rest of your body. Next slide, please. So what are the symptoms? And I should say that endometriosis is one of those diseases that it is quite a spectrum of symptoms. So some people have very mild or no symptoms, others have very severe and debilitating symptoms. It depends on where the endometriosis is growing. But the classic symptoms are chronic pelvic pain and very painful periods, heavy menstrual bleeding, bowel and bladder problems, painful sex, difficulty getting pregnant, fatigue and cyclical bloating. And we do say that many people have period pain, but if it's interfering with your day-to-day life, we would recommend that you go and speak to a doctor about it. And so I think it's a chronic pain condition, as you can see. So if we go on to the next slide, one of the things I'd like to ask you is, given what I've just said, it's a disease that affects 10% of those who have periods from puberty through to menopause. How long do you think it takes on average to get a diagnosis of endometriosis in the UK at the moment? And I can see, and this is an average diagnosis, so this is from when somebody goes to a doctor and says, I think there might be something up. Could you help me please get a diagnosis on that one? So I'm going to give you a few more minutes on that one. We have got the 9 or more years at the moment as up there with about 40%. And so I think that is great. I'm just going to give a couple more minutes, not minutes, a few more seconds on that one. And I think one of the things we find about endometriosis is actually, I'm going to tell you the answer. So the average is actually, I see they've gone in a slightly different order. The average in the UK to get a diagnosis of endometriosis is 8 years and 10 months at the moment, and that's an average. And so we do know that some people get a really prompt diagnosis because their doctor recognises their symptoms and helps them. So for everyone who gets a year or less diagnosis, that means there's somebody who at the other end is having a 15 plus year diagnosis time. And so it is one of the diseases that we do need to get better at recognising the symptoms and believing those with the symptoms. It is significant. It costs the UK economy 8.2 billion a year in treatment, loss of work and healthcare costs. So not to be sneezed at. Thought to be the leading cause of infertility in the UK, although I'm going to add that many of those with endometriosis, up to 70%, will get pregnant naturally. However, it is a leading cause of infertility. And because of lack of research, we don't actually know what causes it yet, and there isn't yet a cure, but we hope there will be one day. So next slide, please. So that's why Endometriosis UK is here. What do we do? Well, as you'd imagine of a charity, we want to make sure that everyone with endometriosis gets prompt diagnosis. We'd like an average of a year or less by 2030, not an average of 8 to 9 years. And so prompt diagnosis and the best treatment and support possible. We work to break down barriers to access to care. So wherever endometriosis impacts on lives, and we want to be a powerful voice driving change to improve things and drive up care standards. The endometriosis community is absolutely the heart of all we do. We do it for those people with endometriosis, and we lead and work collaboratively as a community and empower and advocate people for everyone affected by the condition. We fight to make change happen, as you'd expect from campaigning charity, and we aim to be knowledgeable, inclusive, compassionate, bold, and work with integrity. And knowledge is really important, and one of our big challenges in endometriosis is that there's been such little research, we don't know much about it. And so when I go on to the information about data, you can see how important this project was for us. But to tell you a little bit about things we do, we provide information, so a whole range of things about getting out, meeting people, events, webinars, free leaflets, etc. And we've recently launched a nurse-led helpline to support people. I wish we didn't have to, but unfortunately that's the people aren't able to access care at the moment in the way that they'd like to. Moving on, we also work to raise awareness. And so we work to try and get the word endometriosis known, and we work hard to support people with endometriosis to be able to tell their story. Big thank you to all of those people who do have the courage to do that, because it's by allowing people to understand what it's like to be living with endometriosis that we're able to get our message across. And moving on, one of the key areas we do is campaigning for change. And so we've done work, we campaign to get mental wellbeing in school curriculum, we do a lot of work in Parliament and a whole range of reports. So moving on to the next slide, data is really important, and one of the challenges we have with endometriosis is there's so little known about the condition that it's hard to prove that things need to change. So we do a lot of work. These are data from a 2020 survey actually we did with the All-Party Parliamentary Group on Endometriosis. And so we had over 5,000 responses to this. And as you can see, I won't go through this in detail. As you say, endometriosis has a massive impact, not just on individuals, but also on society, with lots of people prior to diagnosis, but with the symptoms having 10 or more GP visits, and that links back to the average time of diagnosis, 5 or more hospital visits, 53% of people going to A&E, and 27% 3 or more times with symptoms prior to diagnosis. And wouldn't it be great if we could support those individuals and reduce their suffering, but also help the NHS to reduce the time it's taken as well? And so if we move on, we were delighted to work with the Office for National Statistics. I mean, we're a small charity, I should say. We have 26 staff. We have a great team of nearly 300 volunteers who do amazing work to support their peers with endometriosis, but we're not a big charity. And one of the things holding us back in campaigning is finding out some answers about how endometriosis impacts on the wider society. And so, of course, working with the ONS, a great organisation. I would encourage anyone who gets approached by the ONS to try and work with them. They've been absolutely fantastic. Obviously, access to big data sources, as Johnny went through. And the thought that we could, as a small charity, access census data, hospital data and DWP data would be impossible. I should say these quotes I've put up on the side are quotes of people, very common things we hear about people's experience of work when they have endometriosis. It's a condition that the symptoms can be cyclical, and which often gets people labelled as flaky because they're not consistently ill and then get better. And so it's often not considered a taboo subject. It's about periods. People don't want to talk about that, etc. And so one of the things with the ONS is obviously access to big data sources, absolutely top quality results. You know that the figures are going to be right. Nobody's going to question them because the data has been looked at so thoroughly. And one of our roles is that we were very pleased to have an opportunity to collaborate right from the beginning of the project on endometriosis, including providing support with the submission and information, and also what we call public patient involvement, or PPI it's often called. So making sure that those with endometriosis and personal experiences are also fed in. So for example, the ONS have great data, and they were using census data and also the data from hospitals. But we also recognise that a lot of people don't actually have their endometriosis recorded in hospital. And so the ONS have also been looking at if there's other ways of doing that. So I think it's been a really exciting project for us to be able to get that much input. And of course, overall, what we want to do is, for us as a campaigning charity, is we want to help people with endometriosis. We also want to help the NHS save time and money by getting things better. So we want to provide evidence on that one. And if we go on to the next slide, this is I felt quite bad putting this up. These are two summaries of two results that came out of the data. This is an amazing amount of work went into this, and Isabel Ward, who started the project along with Johnny, Emma, and Eleanor and the team, put an awful lot of work in. But we found two very interesting facts for us, and one that Emma's already touched on is that those with a diagnosis of endometriosis, their pay does drop. And the other thing we found out is that on average, people get diagnosed when they're 35. Yet we know that many with endometriosis will start experiencing symptoms when they're in their teens. And so that's quite a long time. Not everyone will, some people get it later in life. And so it also indicates the need for better education. And so what we've been able to do as a charity is then work with the media and with various government departments to try and make the case, on the one hand, for getting better menstrual health education in schools, so that we're supporting those young people, should they have issues with menstrual health, to get a diagnosis, but very importantly, done in schools in a structured and safe environment, so we're never scaring anybody about it, but also are looking at the amount of monthly pay and the impact on the workforce. And if we could go on to the next slide, please. And so this is all generated by the Office of National Statistics, and just to show that in real terms what can then happen. And so what has been great to see with this work is, obviously we have the facts and we can use those, but there is a really big reach, especially for the work on employment and the effect on wages on that. And I think this is just, to me, a real demonstration of how data can be used to try and bring about change as well. So if we just go to my next slide, please. So in terms of, as a campaigning charity, we are looking to get a whole range of opportunity for change for governments. And as I've said, that's the Department of Health, Department of Work and Pensions, also Department of Education, that this data is going to help us with. NHSs across the 4 nations. Clearly awareness in the media, because we need people to be able to say endometriosis, to know that they've got it and look for symptoms, and also for influencing decision makers. There's evidence needs, that we have a guideline from NICE, the National Institute of Clinical Health Excellence, on how endometriosis should be managed, but it isn't always managed like that. So it gives evidence for the need to implement that. We've also been working with the Royal College of Medical Schools about improved healthcare practitioner education, and it's been able to, we can use this to also influence research into further research around supporting those with endometriosis. So as I go on to my end slide, that's a whistle-stop tour around the project, and I will say that it has been a really exciting opportunity for, I should say, not all the data, getting my head around the data wasn't always exciting, but it was always very worthwhile, but a really exciting opportunity for the whole charity to be able to work with such a well-known organisation. And I'll hand back to Eleanor.
Thank you so much, Emma, and thank you to Emma and Johnny. I think this work is so interesting and it's so amazing to hear about the impact. So we're going to move on to our questions section now for the rest of the event, and we've had loads of great questions coming through, so thank you to everyone for submitting those and interacting with the Slido questions. We'll be answering the most popular questions first, so please do give thumbs up to any of the questions that you would like to ask. If we don't have time for your question today, we do have around 15 minutes for questions, then you can always email the engagement.hub@ons.gov.uk email address, and we should be able to answer your question. So let's have a look at some of these questions that we've got through. Great, okay, so the first question is, when GDPR started, we were taught that we should only use the info or data we collect for the purposes that the person has agreed to. How do you overcome this? So I think this is one for ONS.
Yeah, I'll take that, Eleanor. So I'll try not to get too technical, but the legislation that governs ONS is the Statistics and Registration Service Act, and setting out in that legislation, kind of through putting into effect the will of Parliament, if you like, is data sharing powers that allow ONS to acquire the data it needs to be able to produce the statistics that the independent statistics that we would seek to produce in the public good for, for the reasons, the many reasons that some of which you've seen today. And so part of, without going into too much detail, there are some conditions that come with those sections of the Statistics and Registration Service Act that are to do with GDPR, and that's to do with whether the data owner, if it's not us, so if we haven't collected it ourselves, the fact that the data owner needs to be convinced that we are only going to use it for the production of official statistics, and that indeed is all that those provisions in that legislation allow us to do. Yeah, that's the main thing, I think, in terms of answering that question.
Great, thanks, Johnny. I'll move on to the next one, which is health often covers multiple illnesses at the same time. How is this factored in?
I think I can take that one. So in the releases that we've done so far, we've looked at health conditions by themselves. But yes, multi-morbidity is a big topic area, and it's something we've started discussing for our kind of next phase of work. So not something we've factored into this particular programme of work as of yet, but is certainly something that we are discussing and hoping to do some work on this in the coming few months. So keep an eye out.
Great, thank you, Emma. The next question is, it would be interesting to have info on the health impacts of living in a poor quality home and how this relates to people's earnings / availability for work, etc. So I'll ask for a data side, and then Emma, I think I'll go over to you to see if you've got any more about lived experience that you might want to add to this one.
So I can give it a go at answering that.
Yeah,
I think yes, it would be interesting. Certainly, I don't. I'm not too familiar on what data we would have on the poor quality home at the moment. I don't know that Johnny, you know any more about this from your side of things, but yeah, it's certainly an interesting topic idea and how that has health impacts as well. So yeah, can take that away as an idea.
Yeah, I mean, obviously the census itself includes information on housing conditions. And then, for example, during the pandemic, there was some use of VOA data to look at kind of more about the nature of properties and try and bring that information into as extra context in some of the models when we were looking at, you know, the relationship between some of the variables on the census and health outcomes. So there is data out there that potentially that we have access to that potentially could help with research questions that bring that kind of aspect into play. So the data's there, I guess. It's then ONS obviously has decision-making processes with its finite a number of analysts and kind of resource about which projects are taken forwards, including kind of within Emma's team as well.
Great, thank you. We'll move on to the next one. So will data be available at local authority level? The Great Britain work-in programmes is challenging. We need to devise a plan for our area, but local data is limited.
I mean, if I start with that, I don't know, Emma, you might be able to add something, because I'm actually looking at the question below it as well, and maybe if I link the two together, because I think there's two aspects to this. So one would be, just to reiterate, the data we've been talking about today is data that ONS only, in its capacity as the National Statistics Institute, can legally have through its own analysts who are security cleared and trained, etc., to be able to analyse and use. ONS, like the NHS itself, does have a kind of almost a separate function to be able to make available de-identified versions of data available in secure data environments for accredited and approved researchers to use once it's been de-identified, and other things done to it to make it secure. And those secure data environments for external analysts to use have kind of their own versions of the 5 safes framework and various controls and checks and balances. In terms of linked health and non-health data, and trying to progress that as a kind of possibility within either ONS's secure data environment or NHS ones, that's still a work in progress, which would leave any, say, individual researcher at the moment needing to apply to both the ONS and NHS England processes for access to data separately, which would be quite a difficult governance process to navigate, which is why we're working with NHS England to see whether there's something we could do about that to simplify the process for a project that did want to do something that involved linked health and non-health data. If it's about aggregate level data that say Emma's team released, that ONS released, but then breaking that down at LA level, then if that's maybe how I'm interpreting the first of the two, then Emma, I don't know whether, you know, I guess it'll partly come down to the numbers of the cohorts. In the endometriosis one, for example, I saw that there was like 55,000 in your cohort, and it's always going to be a limiting factor to just how granular you can get with the results, I guess.
Yeah, definitely. I think most of them we try and do at least a breakdown by region. But yeah, it is going to be specific to the project as to how far we could go further down than that. At the moment, as I say, we've done region, and I think that's been kind of broadly okay for most of the projects. But if there are specific needs for LA level data, then please do get in touch. And depending on the project, and like Johnny said, like things like resourcing and the projects we've got coming up, that might be something we could look into in the future.
Great, thank you both. I'm conscious we've had quite a few data questions, so I'm going to do one that Emma Cox can answer as well. So we've had a question through about how charities can get involved with the ONS. So perhaps, Emma, you want to talk about a little bit about your experience working with us, and then we can talk about it a bit more on our side too.
Yeah, sure. So I mean, we had an email. We were very lucky, and the ONS were looking at these different projects and were investigating about whether they did endometriosis, and so we were really pleased to work with them very early on to see if it was going to be, if you like, top level feasible, because as been hinted at already, not the records aren't always, you have a lot of data, but are they going to be useful to do? So I think the first thing I'd say is if you do get a call, do what you can to help with the ONS, because certainly we were really delighted to be able to do that. But again, I think the other thing is, as we do all of the charities, don't we, is it's about trying to make a bit of a noise. And so we have the women's health strategy that government had issued, those projects being done. So I think it's sort of that cumulative of trying to identify where data is needed. But it was the ONS approached us in this case.
Fab, thank you, Emma. Also, I'd just like to say that I'm in the outreach and engagement team at ONS. So if there are charities on the call that would be keen to work with ONS, then we are absolutely open to that. So please contact us through the engagement.hub@ons email address. That would be fantastic. I'll move on to the next question. So to what extent do ONS datasets on health and wealth linkage include underrepresented groups, and what methodologies are used to account for the data invisibility?
Shall I start, Emma?
Yeah,
maybe there's a little bit I could say, but you might have some more as well. I mean, I guess the main thing I'll talk about perhaps is the census. So in a lot of these studies at the moment, kind of the census data is our central spine, and that's relatively well known in terms of when the censuses were done in 11 and 21 to understand just how well they captured everyone and where the gaps were. And because of the nature of this work, which is individual data linkage, the census methodology itself includes trying to account for some of the groups and people that have been missed in the harder to count areas and where the coverage is lower. But when we then do data linkage with the census data, we only have the actual records of the actual people enumerated. So we still then have those gaps in the linked data set, which is where there's been some work done on kind of the nature of the cohort that we're then left with compared to the full census enumeration post all the methods work that's done to account for the missing subjects that weren't enumerated. And maybe Emma can say a little bit about that further in terms of the impact then on the actual analysis.
Yeah, so I think it comes down to the kind of aim of each of the projects, and then when we publish it, we make sure that we're quite clear on the people that does include and it doesn't include. So for a lot of our projects, obviously we need people to be engaging with particular health services in order for them to be included in the data that we then analyse. So for example, when we've analysed the effects of NHS talking therapies as a programme, that is caveated to be only those people that have engaged with that service. So it doesn't cover a broad impact of, anybody else receiving mental health treatment through different services, or people with mental health disorders that are not engaging with those services. So we do try to make sure that in any of our releases we are sort of caveating them to ensure that they're being interpreted in the right way, and we're being quite clear and quite transparent of who's included in that data set and who's not.
Great, thank you both. I have another one that we can go to Emma Cox for. So this one that is, I'd be interested to know how the average earnings of those with endometriosis compare to other women of their age and how they differ.
Great. So I don't have all the stats in front of me, so from memory, they weren't that different in terms of that. What we know from people with endometriosis is many do really well, etc. But what we find is that people or some people find they can't work full time. And so what we find from looking at the ONS data, but then more granular data that we've tried to look at, which is not as good quality as the ONS I had, is we feel that probably people get to the same level, but maybe work part-time or that side of things. So there is a lot of data in there, but the main difference that we found, because obviously what the ONS did was look across all different variables around employment, etc. There wasn't anything significantly different beforehand.
Great, thank you. I will move on to the next question, which is how will ONS ensure GP record errors, so 23% of adults affected per HealthWatch, don't undermine the health wealth data linkage?
I think the first point for this would be about which data we currently have access to, which is only secondary care data from NHS England. The primary one being the hospital episode statistics data set. And with those data sets, then Emma's team will liaise with and use the online information that NHS England provide about the quality of those secondary care data sets. For primary care data, we don't currently have access to any. It is trickier from a data sharing point of view. Obviously, if it ever becomes the case that we can access primary care data, which you would kind of need if you want to look at conditions, particularly conditions that primarily only seem to be diagnosed and treated through primary care, you would need that data to have visibility of them to then enable work like this. We would obviously then do similar in terms of understanding as much as possible about the limitations of the data, any errors, any gaps, to make sure that we, at the very least, can be transparent about those limitations in the data, as ONS always is in any release that uses any data set, or further, is there any way to methodologically or statistically account for some of those limitations in the data to actually adjust the results.
Great, thank you, Johnny. The next one is general ONS data. Could data be better signposted for unitary, shire and district council analysis? Struggle at times to find relevant detailed council information. So I can take that one. So that is something that we are focusing on at the ONS in terms of how we can improve our website. So that's something that we can definitely feedback. So thank you for that in terms of hunting for those relevant releases. I'll answer another question, which I think is all the data publicly available in a form that data analysts can interrogate it?
So I think this is the same as one I answered earlier, which is this data is particularly because of its sensitivity, etc., is only legally there for ONS to use to produce official statistics. But then what I was saying about how ONS and NHS England, for example, have a role with their secure data environments to make data available securely in de-identified form to accredited researchers who apply through the appropriate governance channels that both organisations have to then access that data. And yeah, just to reiterate, when it comes to linked health and non-health data, that is slightly trickier at the moment in terms of how complicated that governance process would be. But we are working with NHS England to see whether we can make that simpler.
Great, thank you, Johnny. I won't ask the next question because we've covered it really in kind of LA and local level statistics, but I think the final question I'll take is how has the 8-year delay in diagnosis been how has the 8-year delay in diagnosis been incorporated into the economic impact? So I think that might be one for all of you. Well, Emma first.
Well, I'll do briefly. So in terms of obviously I'll leave Johnny and Emma to talk about the ONS stats. I think for this project, we were specifically looking at wages and time point wages, if that makes sense. It was not possible to link them to diagnosis length, sadly. But I think that I would say for the bigger models that have been done globally, looking into economic impact of endometriosis, it just looks at they're done on the, if you like, averages across the year that would for the number of people who'd be active at that point using different data. But I'm going to leave over the ONS to talk about the data on this.
Emma, do you want to?
Yeah, no worries. Yeah, so the release we did on endometriosis is looking at the economic impacts at the time of diagnosis. So we haven't looked into the delay impact in that release at this point in time.
Okay, thank you both. I will leave that there for questions today. So thank you so much for our speakers and thank you to everyone who's joined us today. Before you go, I will just mention that we do have more webinars in the Bringing Data to Life series that will be scheduled soon, and you can always find more of our ONS webinars on Eventbrite. Before we close, we'd like to mention that there is a feedback form that we would greatly appreciate if you could fill it out. The feedback form just allows us to better understand how you enjoyed today's webinar and if there are any suggestions for future topics. But once again, thank you so much to our speakers and to you, our audience, and see you next time. Thank you all.